Who cares if you give me chemo? What does it matter? My chronic exposure is going to continue. And so I think there's an arrogance that you can fix it.
An average adult only spends 63 minutes in an outpatient clinic with a physician, NP, or PA in a given year. That's 525,537 minutes.
These are complex issues. So there's absolutely no way within the four walls of our hospital system or our ambulatory care that we can address that. That's a non-starter. We can't. People have a really hard time potentially wrapping their mind around that our ancestors may have been smarter than us.
Hi, everybody. Welcome to another episode of Healthcare Without Blind Spots. I'm incredibly fortunate to be joined by Dr. Judy Brown Clarke, Vice President of Equity and Inclusion and Chief Health Equity Officer at Stony Brook University and Health System.
Yeah.
A mouthful. Did I get all that right?
You did, yes.
All right. That's amazing. Good. I'm so excited for this for a bunch of reasons. And before we dig into the important work that you lead, I like to start by asking people about their B-side intro. So maybe the things that people don't know, but like the hardcore followers should know or do know. What's your B-side?
I think my B-side is I am really like, first of all, I play and pray in the dirt. And so I'm a gardener, and it's interesting, now that the weather has finally broken and I'm doing both vegetable gardens and flower gardens, and how much like as I'm, really connected to the dirt, which I think is like the full cycle of humanity and life, from dust to dust.
Yeah.
I find that I can process information and my thoughts, my creativity and so on. So I really have an incredible creative side to me that is like connected to energy as well
Yeah.
as, all the other strategies that, came out of sport.
Love that. Do you have a favorite plant or vegetable in your garden?
So I guess probably my favorite, because it's the more hardy one, is, I really love tomatoes. I love to grill
Okay.
tomatoes. But a little bit of everything. And I think
Yeah.
the flower is, there's like so many. Like I love perennials, I love annuals. So it's hard to pick a flower because I always like the perpetual
Yeah.
bloom because it always gives me kind of that
Yeah.
sense of season. Yeah.
I love that. I love that. Um, you may have already answered some of this because I always like to ask people the topic of joy comes up for me a lot, especially as I've gotten older, and more of it has been like when I've helped friends, peers, people sort of navigating like the next step in their life, and have tried to find ways to help them think about joy and what brings them joy and what
Yeah.
takes it away.
Yeah.
For you, what brings you joy and what takes it away?
I think joy is a choice. You can choose to look at something in a way in which for me, I sort things very quickly. Either everything happens for a reason or everything deserves a meaning. And I don't spend a lot of time on sorting that. So things that I really don't understand or I can't really figure out, like why did this happen? Then I immediately focus on how do I give this meaning? And so the joyful piece of that is really not trying to be in control of anything. I think that's
Yeah,
probably the one thing that people lose joy is
I
they're
love that.
trying to control an outcome. They're trying to control a process, or there's something that, that was unintended. And so I think, the foundation of joy is like being present. It's to be resilient and have grit. And then to always look at, how do I make the most meaningful impact under these conditions? And that's just the joy of life.
Man, I love that. Okay, let's dive into again maybe some of the amazing work that you're leading and some of your A side
Ah,
intro. So Olympic silver medalist,
yeah.
right? CPS investigator, city council member, now chief health equity officer. what's a thread or threads plural that sort of connects all of those together for you?
Hmm. I think from such a young child, it's always been about fairness has been incredibly important to me. And I think the thread of fairness, well, whether that fairness is access to something, it's funding, it's communication, it is ensure that you're represented in decisions, policies, laws, regulatory things. And so I think, it doesn't really matter what table that I'm sitting at. It's like
Yeah,
what I'm always trying to ensure is that we're doing it in the most inclusive and high performing level. Like, how do we do this at an exemplary level? But we're also ensuring that like, every aspect downstream of this decision has been taken in consideration so it does no harm. And so I think that has been, whether I'm working in education or I'm running all over the world and I'm seeing the world in this like global lens of what it looks like what does humanity look like in different countries, value of life, what are entitlements in different countries. I think all that has kind of culminated in my ability to be very present in a way and without judgment and trying to be as inclusive in whatever I do.
really great. As part of that humanity, I can only imagine the work in CPS, seeing families and children sort of in the most challenging of times.
Yes.
Um, if you think about sort of that time and sort of where you are now in healthcare, what are the what are the blind spots that we have in healthcare about those challenges that families are facing and the struggles that they have and what they're trying to get through?
I think one of the things that I learned, particularly in children's protective services, is in a way in which I always had like, this authenticity that I could be standing in your position. I could be standing in a child death. I could be standing in physical abuse. I could be standing in mental neglect. But for some incredible blessings. And so I think what I learned about kind of the social determinants and drivers of health, that's a byproduct, So if you have if there's literacy issues, if there's access, to financial stability, if there's not, health care that's available, it's all these things will manifest in how you care for your family. And so it became very obvious to me is like, whether we had a medical neglect, or we had something where there was like educational neglect, if you have not had a great relationship with your educational experience, it's very hard for me to hold you accountable to making sure your kids go to school every day to something that treated you
Sure.
so poorly. But there's an expectation that that institution it deserves respect, and or you don't have the means to buy a prescription because you don't have insurance, so you can't pay the copay. If people tell you you should have fresh vegetables, we know the cost of eating something fresh versus canned or frozen. So there were so many things, socially determined social drivers of
Yeah.
health that were just people's truths, their lived experience. And so I think I was, really understanding the health equity piece of that. And it could be financial health, it could be environmental health.
Yeah.
So it just to me just became kind of an evolution. It's like, oh, so what we're calling it now is health equity and social
Right.
drivers, but my entire life and well before me, it's always been the tough times.
And it's just to me, it's life. And
Life.
I think a lot, been talk a lot about, and I say this as a former practicing physician, like
Yes.
we are so egocentric in healthcare. And I don't really mean that in a bad
Understand.
way, but like we, we think about the disease that somebody has
Yeah.
and where they go for care and the
Yeah.
medications that we prescribe and believe that because we understand that we have such great now research on evidence-based medicine and
Yeah.
all the things, right? We're going to put somebody on a treatment plan and like, and there you go, we're done. Like,
Yeah.
we
Yeah.
did it.
And then you're
And it does.
non-compliant if you don't do it.
Right. 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 I know, such an interesting phrase, is it? The
Yeah.
non-compliant
Yeah.
part of that. And to me, and thus the name, like when we were thinking about the name of the podcast, this blind spot that we have
Yeah.
to everything outside of the four walls of a clinic and a hospital. And I think you have a similar sort of numeric thing that you hold on to. I talk about the 63 minutes. So on average, an average adult only spends 63 minutes in an outpatient clinic with a physician, NP, or PA in a given year.
Yeah.
That's 525,537 minutes outside.
Yeah.
I think you've got a 363 days in the community. Is that right? Do I have that right?
Yeah, well, and you know what? It's so funny that you picked up on that because I always say, like, a broke clock is right twice a day because it's just going
Right.
to land on
Yeah.
that. And so every once in a while we get it right without any effort. But then the other part of it is there's a need to be a continuous intentionality as to how we provide that care. And so, do we stay curious with non-compliant? And what are some of the barriers to being compliant? And when we give medical information, do we understand it from a literacy? Do we understand it from a historical mistrust? But there's like so many things that really affect, when people come in for that short period of time that they're coming in for their office hours, or if they're
Right.
inpatient or outpatient and so on. But you know, their whole ability to comply is so complex. And I just,
Right.
how do we keep our clinicians in a way in which they stay curious to not necessarily looking at your disease, but what are the levers that are driving this disease? That if it's foodborne, it's a
Yeah.
foodborne illness or it's managed through exercise. So do you have a walkable community?
Yeah.
Like, where am I going to walk? Like, and I always think it's interesting, and I always have to smile to myself because this is people's full scholarship when we talk about sleep deprivation. Tell me someone that can't pay their bills, is in domestic violence, is in a high crime area, is not employable because they don't have the education or they may not have even the ability to buy a uniform. And then you talk about sleep. Like,
Yes.
sleep is a privilege.
It is
It's
so
a
much of what we do is a
privilege.
privilege.
Yes.
Yeah. And it makes me think of the word perspective too. Like
Yeah.
even well-meaning, we lack perspective.
Yes.
And I think, like, where's there the opportunity to create perspective
Yeah.
as, like, and I get so focused on healthcare and our roles as health systems, as practices, and what that means as part of that. And it feels like we're putting more and more
Yeah.
right on the provider as part of that. And yet this is how I think about it. Like when we talk about social drivers of health and the impact
Yeah.
on health, there's the 80-20. Like 20% of your outcomes
Yeah.
are it's healthcare, and 80% is social. And
Yeah.
I've said this before on this podcast, but I was delivering we have, of course, a slide that has that on there, and I'm
Yeah.
talking to a bunch of doctors who were in a value-based care arrangement. And the executive before the meeting was like, Trenner, are you really going to tell doctors that their life's work is only 20%? And I'm like, no, actually, I'm not. What I'm going to say is the 20% is the most important. I want everybody
Yeah.
to get in and get seen, to
Yeah.
get diagnosed as
Yeah.
early as possible, to
Yeah.
get the right treatment, to be able to take
Right.
their meds, to be able to follow through, see special, all the above. What I'm saying and what we see across this country and across the world is that the 80%, the barriers and challenges in somebody's life prohibits them or makes it that much harder for
Yeah.
them to participate in the 20%.
100%.
We're trying to clear those barriers, right?
Yeah.
And how do we help people sort of see that?
Yeah. I think, and I think, uh, I think it's an arrogance to think,
Right.
as we stand as clinicians, we know there's an arrogance to think that, my intervention, this single point of entry, this pill, this shot, this
Yeah. Yeah.
this this procedure is going to cure it. When we know that there's like it's a complications, like how can you cure my cancer when I'm next to something that's, giving me a constant exposure to toxicity. Who cares
Sure.
if you give me chemo? What does it matter?
Right.
My chronic
Right.
exposure is going to continue. And so I think there's an arrogance that you can fix it. So if we can tap her down, it's like my 80% will contribute to my 20% will contribute to the 80%. And quite frankly, what I need to do is I need to empower our patients and the communities that surround them with our
Yeah.
nonprofits, with our municipalities and so on. It's like, how do we do no as little harm as possible? And a way in which we're a good neighbor.
Yeah.
And so I think part of that is like, so much is like, I can only influence 20%. And it's like, did your ego think you had more? Because you didn't. You really didn't. 'Cause your little
Right.
30-minute, 20-minute, get 30 minutes actually, like you've
Right.
gone past so you're holding all
Right.
your patients up, but your little bit of time, it's like that's an incredible amount of arrogance to think that your intervention is a solution.
I think we like, and you use the word too, like we like to fix things. Like, and it's, I mean, for all the right reasons. And
Yeah.
I think it's just sort of and I think the challenge in sort of our US healthcare system is there's so many things outside of the control, like of the health. And it's just, even as you talked about like joy before, like some of it is just letting go that you can't control it, right? At the
Right.
like, it's not your, and instead of thinking how do I control it, it's almost like a river, like how do I get in it
Yeah.
and participate
Right.
in it, and what's my role as part, and what's everybody else's. So as part of that, and in your role now, how do you think about sort of what happens appropriately related to health equity, and what inside the four walls happens, and balance that with all of the things outside the four walls? And we can, like, I'd love to dive in there because there's so much fun
Yeah.
to talk
And
about there.
I think, one of the ways is that we have four walls. It's like, there's absolutely no opportunity, single disciplined, single entry. There's like, these are complex issues. So there's absolutely no way within the four walls of our hospital system or our ambulatory care that we can address that. That's a non-starter. We can't. And so like what is the continuum of care within that person's community? So do you have access to food, to exercise and activity, to literacy, because literacy, like the whole point of your ability to be empowered and have independent critical thinking is your ability to consume information. Well, that requires literacy. So part of healthcare is literacy. And we don't think about that. It's like, like we need literacy. And it's not just like, English as a second language. No, literacy. And decipher where do you get good information versus the noise of social media. So all that is part of, empowering your patients to make good independent choices. We
Yeah,
don't think about that.
we don't. As you help health system make decisions about investment into the community,
Absolutely.
how do you like, how do you sort of go through that process? How do you get people on board? How do you help? So I'll give you my bias first as part of
Sure.
this. Um, is my worry all along has been that many people think of addressing social risk and social determinants and social drivers. This is like a nice thing to do. Like we're doing the nice thing. I believe it is fundamentally part of, frankly, the business of medicine. It is integrated into every part of how we're going to manage cost, how we're going
Yeah.
to manage clinical outcomes, how we're going to manage quality as part. So how do you, again, help an organization, right, who's got so many priorities, appreciate that the investment into the community like makes a difference, not just, again, as a nice place to be and a nice partner in the community, but makes a difference more broadly to the organization.
Well, and I think, like, what are the perfect models? The perfect models are in business, and healthcare is a business. And
I
so the whole business is meeting the needs of your consumer and your customer. And so the customers are our patients and the people that we collaborate with. And so, you have a choice. You can come to Stony Brook or you can go somewhere else. So why would you come to me? You come to me because you're going to get a high quality level of healthcare, that you trust me and I'm authentic, and that I see you as a patient. I'm connecting with you and I'm developing a relationship. And I don't just see you in the when you come into my, examining room. I also see your community. So you're not just seeing me because you come to me, I also come to you. So we have
Yeah.
mobile vans, mobile mammography and cardiac care and dental medicine. And our social workers go out, our public health students go out. So we're in your community. So we don't just see you when you need, we're not on demand. We don't just see you when you need. We're there to also mitigate issues that are happening in your community. We're at your the picnic, we're at like the health fair, we're at the school, we're at, the senior citizen home, and making sure that we're taking care of our most vulnerable populations. And so that seeing people physically demonstrate that they care about you, not just the fact you can pay your copay, but they care about you as a community member because they are part of your community. That is part of really developing that relationship with communities and that reciprocity so that when you have a choice because you need an x-ray or you need
Yeah.
a provider, like you're going to come to us.
Yeah. Do you have a story that you want to share either about a patient, a family, or a community organization and sort of the way that they're leaning in and getting supported or providing support in that way?
Yeah, I mean, yeah, I mean, we've had, particularly when we were, like with our, getting a mammogram is a luxury. Actually, I'm gonna go to our mobile dental clinic.
Okay.
Our
Yeah.
mobile dental clinic, and I don't know why, and I've been told why because I understand it's political, but why health insurance does not cover vision and dental as a carve out. It makes it seem like, the health of your eyes and your mouth are absolutely not critical to basic health. That's just ridiculous. And
It
usually it's
is.
a right, so like you get your health care, then you're like, oh, and do you additionally want, vision and we know that your mouth and your eyes are like the canary in the cave to your
Yeah,
health.
100%. Of course. Diabetes, hypertension, and so many other things. Yes.
And so
Mm.
your ability to see things in a really, uh a primary versus secondary and tertiary, like really early on, gut health with the breath, and I mean, so there's like so many there's like so many things that you could. So one of the things that we do is like, we have the dental clinic going into places that we know we do not have access to good dental care and people
Yeah.
that do not have any kind of health care as well as those that, may have care that most people will not accept them as a patient because the reimbursement is so low. We also provide care for cognitively, um, like with our autistic population, including kids, in which we will allow them, put them under and then, do their dental work. And we've had individuals, I was talking to our dean of dental medicine, and he was telling me that, we have individuals that are bringing in a 45-year-old that has never ever, with sensory issues, has never ever had their teeth cleaned. So you have to know at 45 the amount of decay and
Yeah.
just
Yep.
those things that, we've got these other points of intervention in a way in which is compassionate that, that our dentists, our dental students too, because we want to create the next generation of
Yeah.
providers,
Of
but our
course.
dental students
Right.
are, providing the best level of care in where they're meeting their patients where they never would have been. So we're also teaching our dental students to understand what the social determinants of life lived real time and
Yeah.
the way in which they've never been in neighborhoods like they've been in, providing the care and seeing worst case scenarios of people's mouths and thinking like this is something I would, like particularly if you've seen somebody that's had a meth mouth or like
Yeah.
if you've seen a mouth of a homeless person or someone that is has, long-term drug use, I mean, that mouth is really in bad shape. And so you have to know that person's sick. And so where would our students get the opportunity to develop the humility, the compassion,
Yeah.
to treat someone who they never would have interacted under any other circumstances, and then hopefully take that into their dental practice? Those are like some points of pride, and I have them in others too, but like
Should be.
that is
Yeah.
just, or like I said, like our autistic population where, with their sensory issues that, like people can't touch them, like they don't get their teeth cleaned. It's like it is a major traumatic, to between, all the things that go to getting your teeth clean, let
Right.
alone getting a
Yeah.
filling and whatever. And that they have the dignity and the ability to have a positive, and at some point in time, if you come every 6 months, then it's not as scary, and at some point in time that we don't have to put you under. Maybe
It's,
not.
I mean, so many of those things are about building trust,
Yeah,
relationship, being there for people,
yeah,
which I deeply appreciate. I also, I mentioned to you earlier, I trained at Marshall in West Virginia. And so
yeah,
part of that training was going into
yeah,
others, like
yeah,
into some interesting places, right? That I had never been
yeah,
growing up, even though I grew up like in Southwestern Virginia. It's not like I grew up in a big city, but it still was just really different. And perspective and empathy and compassion. It's
yeah,
such like to be a great provider,
right.
broadly speaking, like it is such a necessary skill,
Yes, it
in
is.
my opinion, right?
Yeah,
To be successful. Staying in the community just for a second, I
sure.
know faith is important to you. And I think about the role that religious organizations or
Yeah,
churches play in connecting, being part of the community, but also connecting to people, the trust and relationship
yes,
that those institutions have with their congregation and their
yeah,
members. I remember doing work in Memphis where they were working with the health system, but part of what they talked about so eloquently, this was Methodist Lebanon health system down there, like 756 churches like in their broader community
yeah.
and the role that they played. Do you have a perspective on sort of how to get value in the role that those organizations can play as part of this sort of broader health approach?
Yeah, I think it's really interesting, and I was reading some data, and I can't remember who was doing this poll, but they talked about, particularly for young people, so I think it was like 20 to 40, that this new, re-engagement in faith. Because pre-COVID, there was like,
Yeah,
decline within our faith, aging populations within the congregation and so on. And so like there's this reconnection with faith. And I think that people need to know that there's something is bigger than them, that there's always a level of hope. And sometimes it's hard to look at hope unless you can put it within kind of a structure of faith, or spirituality. And so I think that's very helpful. I think that's very helpful within, our structured religion. I think the other piece of our religions, like sometimes our religions had very tight rules. and
sure.
and so as we raise these generations of, being inclusive and, like love everyone, whatever, and then, then we get
Sure.
very
Yeah.
tight within
Yeah.
our religious structure, and so we kind of get these mixed messages. And so being on a college campus where, many really faithful families, like this is the first time that the students have been able to make their own personal commitment to faith, and
Sure.
they're, struggling because of the mixed message.
Sure.
And
I'm
so I
sure.
think, I think what I have heard is across all religions is, and I mean, still there's very steep in doctrine, but I have heard more of an inclusiveness, including like you think about the Catholic, and not having a female priest, and like, so there's been an evolution within many of the religions. Um, in a way in which it has been more inclusive, some more than others, let's
Yeah.
be honest. And
Yeah.
so I think I I think some of that lowering of not being connected to faith or spirituality, it's hard not to be hopeless because there's not something that you can focus your heart and
Yeah.
soul towards in a way in which it feels like it gives you hope, it gives you grace, it gives you aspiration, it gives you the opportunity to let go of things. When you talk about joy, sometimes prayer is
Yeah.
go. So if you don't have those, and if you don't have those opportunities to do that, then you hold on, and then it just kind of becomes, just like, self-hate then turns into you, and then, and
Yeah.
everything that manifests from that.
Yeah. And I think too about the role that churches and religious organization, mosques, synagogues, etc., play in our lives and the lives of the community members, and in terms of actually addressing social risk. And I think about
Yeah.
meals that are provided,
Yeah.
community, right, to address social isolation, potential financial support in
And
different
yeah.
ways. And it's one of those things when I think about, like, when we ask individuals, like when we survey them, right, or we think about like using like data like that we have as part of that, like, are we taking into account the role of those
Yeah.
organizations and what they do, and both the support that they can provide? How do we get real,
Yeah.
again, how do we, I think of our responsibility like this work as a team sport.
Yeah.
And so for,
Yeah.
for an elite world-class athlete, for
Yeah.
you, like it is like we get one chance at this. Like, we, as opposed to thinking as everything is separate and distinct, like, how do we get everybody, all of us, responsible sort of for each other, with
Yeah.
each other,
Yeah.
like the roles there? What's the role of the health system? What's
Yeah.
the role of government? What's the role of employers as part of that? What's the role of health insurance companies as part of that? Like, I can't imagine us winning if we can't figure out how to play like a team.
So here's where I love, what I think, people have a really hard time potentially wrapping their mind around that our ancestors may have been smarter than us. So if
Tell me more.
yeah, yeah. So if you really think about, and we talk about bio-inspired solutions, right? So nature is brilliant. There's so many things that we have observed in nature and created a simulation that has become a solution to something that feels like it's insurmountable, right? And also, what is great is, like, if you think of, like, stories and fables and parables and things like that, you realize that while they were using animals, because they really were talking about people, but that's you have to defend if you're talking about people, but if you use animals and you can say a whole lot, just
Yeah.
like comedy. So, I think it's a little bit of stone soup because, like, nobody has a full meal to feed the community, right? So, if we can bring the pot and then we're like, "Okay, we don't have all we have is this damn pot." But if we can bring the pot, and then it's like, like, it would be really great if somebody had some wood. Somebody can, somebody had a match,
Yeah.
somebody had a piece of meat, somebody had what, and pretty soon, like, all these, like, no one has a full solution. But if everybody puts their resources together in a way in which it leverages each other, all of a sudden we have this hearty meal.
Yeah.
And so I think, to your point back to using your local information brokers, which is like, your clergy,
Yeah.
people within faith, and like your nonprofit organization, like everybody has a piece of the solution. Like they can provide this piece of it, but these other things are needed. Absolutely, which is why we have this group. So that continuum of care and that social network is like, how do you ensure that those things are connected in a way that the handoffs, it's not like listen, let me make a referral to you and I hope you can figure out your way to get over there. It's like, can we have intentionality in our handoff? Can we ensure that people understand that the system can help them navigate it, not the person needs to navigate the system. Can the system
Right.
help you navigate? And I think that's what's missing.
I love that. It also makes me like one of the players, and I say this, we spend so much time with health insurance companies across all lines of business, Medicaid,
Yeah.
Medicare Advantage, commercial, as part of that. And you talk about the handoffs, and I think about all of that health plan sort of offers, right, as part of their insurance. They've got care management programs. A lot of them have CHW
Yeah.
programs. They've got vendors that they've contracted in around
Yeah.
whether it's engagement or support interventions like for rides. And yet it feels like that information is like a black box
Yeah.
if you're on the provider side.
Yeah.
And yet that same person who's a patient is a member here. It's the same person. Um, what if you had, I don't know, a magic wand or other tool or just an ask, like what do you have an ask of like how health insurance as part of that developing of the hearty meal, like how did they be a great partner for provider organizations?
Yeah. So back to the stone soup, it really was the person that was holding the pot, right? Because the person that was holding the pot was telling about what needed to go in the pot. So people could have
Yeah.
just thrown a rock in there. I mean, like the stone, of course, the stone soup, like, well, let me put
Yep.
another stone in. So we have two stone soups. It's like somebody has to own it. And so I think there has to be a continuous improvement process, and somebody has to own that continuous improvement process. Like, where are there gaps and unmet needs? Where are there inefficiencies? Where is there not enough funding so that when, there's a handoff, there's actually, a support service or something that can help, so it doesn't really matter if I make a referral to a specialist, but you can't get there. So like, do you have tokens or do you have, Uber credits and things like that? I mean, so,
Yeah.
but who makes sure, like who owns that process and continues to say, hey, patient, I understand you used our credit for Uber. Did that work? And you're like, yeah, it did. But you know what? Here's where it didn't because nobody wanted to accept the Uber. So can you contract certain Uber so that they come because
Right.
everybody kept canceling because you were whatever.
Yeah. Yeah.
I mean, so like if somebody kind of owns whatever the continuous process and it's always continuously being assessed. Is this working? Are you happy? Like every time you go to the bathroom, right? You walk out, you have the little three happy faces and you hit one of the buttons. Like what mechanisms, low risk, low calorie mechanisms
Yeah.
ensure you have your hand nimbly on the pulse of, is this continuous process working? And if not, how do we intervene real time?
It's such a from a work standpoint, that's an amazing place to be and live. And I love that a charge for all of us
Yeah.
as part. Before we end, I have one last sort of personal question that you may, if somebody as talented and accomplished as you are, may not have struggled with this. I talk a lot about imposter syndrome, and like being in a room and looking around, like why I'm supposed to speak. Wait, what do you want me to do? Like, you
Yeah.
want me to lead what company?
Yeah.
Um, can you talk about your experience, if any, with
Mm,
imposter syndrome? Imposter syndrome.
absolutely. And of course, I've had some birthdays, so I have a different perspective of it. But it's funny because I talk to young people all the time. I've got a bunch of mentees, and I'm always talking to student groups, whatever. So my imposter syndrome speak is probably very different than you're probably going to expect. So here's my so I fully respect there is imposter syndrome. And when you walk into situations where you're the only one, or it feels like everybody has a set of skills or knowledge that you don't, or it feels like people got in the room for a different reason than how they think you may have gotten in the room. Um, so it is absolutely okay to acknowledge that. What you don't have permission is to stay there. So I think most people, when they are standing in there, like with this about like, oh dear God, like how did I get in this room? Is to default to I don't belong here. Or oh my goodness, I'm gonna focus on the fact that, what is the deficit as to why I'm here? So we're not gonna sit in that deficit model. We don't have time. Sorting laundry. Everything happens for a reason or everything deserves a meaning. So that quickly, you need to figure out, you need to bridge. What is the information that they have that you don't have? How did everybody get in what are the politics and dynamics of what this room is? How are decisions made? Um, and not really feeling like I need to make you comfortable. No, I don't. I really don't. I have, you know
Yeah.
what? Like your comfort level, I will oversleep tonight because I don't care about your comfort level. So my whole thing is like, we can't be so enamored. Like so many people are enamored because you're the first. You're like, oh my goodness, you're the first. Well, hey, that's because I'm old. But there's not a whole lot of first left there. But so there's a whole lot of opportunities to be the first. So you can't be enamored with people that are the first and you don't want to be the first. So being the first or one of few means you come into the room, and typically when you come into a room and you don't see yourself in the room, is there's a high likelihood that that room is not prepared for you and your perspective. So it means that, okay, I'm coming in the room that most likely does not have my perspective, but my perspective is valued because that's why I'm in this room. And it's very important to have the most highest level of decision making and collaboration and thought process. And so my responsibility is to make sure that that happens. And I'm going to contribute in the way that I can. So it is not about
Love
me
it.
right now. It is not about me. And it probably won't be about me again. And so my responsibility in that room is not about feeling comfortable. My responsibility in that room is to make sure that every voice that is not in that room is heard and a part of that decision, and that things that are not efficient or effective are addressed. That's my responsibility. That's what I need to be focusing on. So that's how I look at, what it means for imposter. It's like, it is okay, but like sorting laundry, you don't get to stay there.
Yeah.
That's not,
I
you're not
love
the martyr here. You don't get to stay there.
I love it's not about the deficits, it's about what the value that you bring.
100%.
What a great way to end. Thank you so much for spending time with us
My
today.
pleasure.
This was amazing.
Thank you so
And
much.
hopefully we get to talk soon.
I would love that. Thank you so
Yeah.
much. And thank you for amplifying your voice and to really talk about, ways with intentionality that we can do no harm and do this in the most exemplar way. Gold medal to you.